Hello, everyone. Thank you for attending. I have had the great opportunity to collaborate and assist multiple organizations with their audit activities. So, as you know, there are many factors that affect our audit plan strategies. In many cases, there may not be sufficient resources to address all the areas that we may want to explore to ensure coding and documentation compliance, especially with the constantly changing regulatory environment. It is important for HIM or your audit department and business office team to communicate regarding denial trends relating to coding for the potential educational opportunities that might present itself. My goal today is to review elements of audit planning with recommendations and to also discuss some of the areas that regulatory agencies will be reviewing this year. The strategy and priority areas should be selected based on the needs of your facility because, as you know, we're all different and different payment methodologies, but this should give you kind of the basic overview of what you could be looking at depending on your resources. I like to categorize audits in three different areas based on the intent. Of course, we can break this down and get a little bit more granular, even more, but for the purpose of today's, this will be our focus. So we'll look at compliance from a compliance perspective, which you're assessing your coding compliance with regulatory and coding compliance. So that could be your routine, whether you're doing it on a monthly, quarterly, biannual, or annual basis. And then also education and follow-up and review. You'll see in each of these areas, I really focus on the education and follow-up review because that leads you to a complete audit program. The next category, focused reviews, and that is a broad category. So it's any targeted review based on the concerns and needs of your organization. And again, any findings that you have, you do want to share and perform a follow-up review to make sure that there was understanding. And then provider documentation, of course, assessing for documentation improvement opportunities, and then also education with your providers. And I would also do a follow-up review at that time as well. For compliance review, if you have not reviewed your coding or provider documentation in a while, I do suggest doing a baseline first to see where everyone is currently at. As far as the provider documentation, I do believe that some form of review of the provider's documentation should occur at all levels of audits, whether it's your compliance audits or if it's a targeted review. A complete audit process is not really a one-size-fits-all. It should include to some degree each of the types of reviews that I just discussed. Excuse me. So I'm going to pull up a couple of polls, and they're just basic questions to see how your organization handles your audits. Oh. So the first question is, does your organization review the audit plan on an annual basis? I will give a little bit more time for you to vote. Okay, so let's look at the answers for this question. Looks like we have 51% that said yes, they do review their audits on an annual basis, 18% no, and then 31% are indicating that they're not sure. A total of 91% actually voted. 51% is pretty good. It definitely should have review your audit plan every year because there are changes that occur during the year that you may need to account for. So let's look at the second question. How often does your organization conduct routine coding and documentation audits? On an annual, quarterly, or monthly basis? Okay, I will give it a little bit more time and then we'll go over those answers. Okay, it looks like we can go ahead and post those. So 11% conduct their reviews on an annual basis, 27% on a quarterly basis, and 41% on a monthly basis. We do have 20% that we're not sure. That's good to see that many doing this on a monthly basis. So again, it does depend on the resources that you have and what your focus is. Okay, so we will close this poll. Thank you for those responses. Okay, so I thought we would go over general recommendations now. So what I recommend is reviewing the different sites to see what regulatory agencies are focusing on. It doesn't mean that that is what your priority will be, but it's always good to go to those sites and see what they're going to be reviewing for the year or what's still out there. So you review CMS site. They have on the CMS site, if you go to monitoring program, they have their list of programs, auditing programs. And what they do is they have reports that show you the statistical information of their findings based on claim type, provider type. It's just a lot of good, useful information. The second place I would go is definitely OIG's work plan site, and I do give you those addresses on the reference slide. Also review state and regulatory program requirements, and I'm thinking more for your rural health clinics and things like that. And then again, review your compliance audit plan or program on an annual basis. The things that you want to ask yourself is for your routine audits, is the random sample that you're pulling, is that still sufficient for this year? Do you have the resources to increase it if that's needed? Or does it need to be decreased because of resources? Or do you just need to look at a totally different strategy? Are there any elements missing from your audit plan for routine audits? This would be the time to evaluate that and then make sure that you include those those elements if you can. And then look at the effectiveness of those audits, meaning from the time that you audit the samples that you're pulling, are you getting the same, are you really getting a random sample or not? Is it giving you a wide view of what that coder or provider is performing or coding? The feedback, is the feedback working? Are you seeing improvement in scores? And then also result tracking. You want to make sure that you're tracking not only the fact that, okay, I performed the audit, but what those results are, what the education is. Is the education working? For focused audit, the things that you can look at is who are your top payers and do a review based on that. You can review your top to 20 services, DRGs, or HCCs, your Medicare Advantage risk adjustment. Review updates to the OIG's work plan. They update that on a quarterly basis. So every quarter, just glancing in there to see if there's anything new, because everything on those monitoring program findings, of course, and the OIG work plan will not necessarily be relevant for each facility. But someone at your facility or you will know which ones are significant and which ones you will need to focus on, or should focus on, I should say. So also the CMS findings from improper payment reports, state and regulatory requirements, and of course, updates and continuing PHE flexibilities, because we know that they've extended the date for that. So we're still able to, because of the difficulties of the pandemic, there's still some flexibilities that we can make use of. And then also, you know, the focus audit is more about looking for issues. Are we coding this compliantly? Is the documentation compliant? And so you never want to include your focused audits or targeted audits with your routine audits. I would definitely keep those separate. So as far as priorities, I would say definitely your routine audits. You want to make sure that those are done and to stick to your schedule. Formally, if you need to change anything, make sure that it's documented, because these are usually going to be connected to your overall organization's compliance plan. So you do want to make sure that you're following that as closely as possible. Any areas of concern that you find on the routine audit, you can definitely move that element of concern into the focused audit area and put that on your schedule or schedule for a review to be done to see if there actually is a concern or not. So once you move that into the focused audit, of course, you're going to do a more detailed analysis. So moving on to the types of regulatory audits, of course, I don't have everything today because we only have 30 minutes. We're not going to talk about commercial or state specifics, but what we will discuss is improper payment, Medicare fee-for-service compliance, and then the OIG. So as of August 11th, CMS has resumed audit activities for their improper payment programs. What they did do is they adjusted some of the elements for some of the programs due to the pandemic. And the reasoning is because the improper payment measurements cannot be paused for an extended period without missing statutorily required due dates. So data collected for 2020 is based on basically information that providers and suppliers provided to them voluntarily, and then just information that they also had on hand. So the first program is comprehensive error rate testing, which measures improper payments for Medicare fee-for-service. They use a statistically valid stratified random sample of all fee-for-service claims. And this is going to review coverage, coding, and payment rules. As I said, for 2020, that review was temporarily suspended. They're resuming it for 8/11. So what they'll be doing now is sending documentation request letters and conducting phone calls for reporting year 2021 and 2022. And you can see I've added those dates, the date ranges for the 2021 and 2022 reporting years. For the adjustment, there will be a sample size reduction to account for provider or supplier difficulties during the pandemic. The top 3 error findings was insufficient documentation, medical necessity, and incorrect coding. If you've reviewed these reports before, whether it's OIG or the CMS reports, this is a common finding. Every year, this is kind of what I see on those reports. Under insufficient documentation, you have missing inadequate orders, missing inadequate plan of care, missing inadequate records, and then certification and or recertification requirements are not met. So under insufficient documentation, a valid provider order or the intent to order for the services and or supply was not submitted, or it doesn't meet the required elements for the order. What's also included under that is a valid provider's plan of care for the service was not submitted, and again, it does not meet the requirements. Required record was not submitted or has not been fully completed, and then again, certification, recertification requirements were not met. For medical necessity, adequate documentation received to make an informed decision that the services were not medically necessary based on Medicare coverage and payment policies. So basically, the reviewer received adequate documentation, but the documentation, they were able to make that decision. Documentation did not support medical necessity, basically. And then incorrect coding, of course, documentation is not supporting the codes that were being billed. The incorrect provider was billed and not showing on the actual documentation, and then incorrect site of service. The no documentation is there was never a response from the provider or supplier to repeated requests for documentation, or the provider or supplier just didn't have the documentation to supply. So just a couple of rates. The national rate, the overall rate, is 63.1% was due to insufficient documentation, 16.2% to medical necessity errors, and 10.9% to incorrect errors. By provider type, it was for hospital outpatient services had the highest rate. Then in second place was inpatient rehabilitation facilities. And then we had skilled nursing facilities and then home health. Let's see, for SNF was actually second for the highest rate for insufficient documentation. Home health was third for insufficient documentation and second for medical necessity. Then if we look by claim type, you'll see that Part A, there's a Part A excluding hospital inpatient perspective, and then Part A, which is the hospital. Part A excluding hospital is high for insufficient documentation at 28.9%, with Part B leading at 22%. The Part A excluding hospital is 8.9% for medical necessity, and then incorrect coding, 7.1% for Part B. So the reasons that I look at these things is it helps me to kind of figure out where my focus is going to be. Does any of these things, those rates, is that anything that I've looked at before or reviewed? And do we need to? So the other part of this is Part A, findings. And again, it follows the same pattern. The certification, provider's intent to order is missing, inadequate order, missing order, medical necessity support, and plan of care content. So if we go to each of these findings for the different types, Part B findings, same thing, support for medical necessity. inadequate documentation to support the services were provided, intent to order is missing, and then actual missing orders as well. For DME, same thing. It's the orders, documentation not supporting or it's inadequate to support coverage criteria, and then also inadequate or missing proof of delivery. So basically, you would want to look to see what those requirements are and make sure that you're meeting those. The next one is payment error rate measurement. And this was designed to measure improper payments in the Medicaid and children's health insurance programs. So this one, I mean, it's the same thing. Verification of documentation sufficiency is what they're looking for. Was the documentation received? Did it support the services that was billed? The documentation supports the date of service. So how many times have we seen where because of the EHR, there's different dates of service from what was scheduled? Does the documentation include signed physician orders? And then again, the certification and recertification for inpatient services, long-term care, and home health care. The procedure or service documented in the medical record is reviewed to determine if the service was covered under the state's policy and if there were any applicable limitations. So we're looking at units and quantities. And if the provider service fell within those limitations, they're also going to confirm medical necessity, as we said, basically reviewing of the record to determine if the service provided was consistent with the symptoms or diagnosis under treatment. So on this table, you'll see basically what was the top 3 errors for those 2 programs, the Medicaid fee-for-service and then the Children's Health Insurance Program. The Medicare fee-for-service compliance designed to prevent, reduce, and measure improper payment in fee-for-service. What's included in that is your TPE audits, the Target, Probe, and Educate, and then your RAC audits, your Recovery Audit Contractor audits. Per CMS, most providers increase their claim accuracy for TPE within the 3 rounds with post-education. They audit 20 to 40 claims, but if the provider is not successful within those 3 rounds, then they do refer them to CMS for next steps, which could be 100% prepay review, extrapolation, or referral to recovery auditor. This audit is intended to quickly increase accuracy in very specific areas. They look at providers and suppliers who have high claim error rates or unusual billing practices, items and services that have high national error rates and are a financial risk to Medicare. So when you look at the common findings, again, certifying signatures not present, the encounter note did not support all elements of eligibility, medical necessity is not supported by the documentation, and then the initial certification or recertification is either missing or complete. For the RAC audits, again, identify and correct improper payments to prevent future errors, performed by post-payment review process. So here's the approved issues. For 2021, they're looking at medical necessity and documentation requirements for the vagus nerve stimulation. This is specific to ASCs, outpatient hospital, and pro-fee services. Were the services reasonable and necessary for patients with medically refractory partial onset seizures for whom surgery is not recommended or for whom surgery has failed? And then also, is it reasonable and necessary for treatment-resistant depression when furnished via a CMS-approved study? The next one is specific to pro-fee, incorrect coding of anesthesia with multiple surgeries, payment for anesthesia services associated with multiple surgical procedures for multiple bilateral surgeries. We have ambulance transport subject to consolidated billing for SNFs, medical necessity and documentation requirements for hospice continuous home care, 2020 is when this was initiated, but they are still looking at these things. Incorrect coding for the distal claviculectomy, excessive units of nerve conduction studies, and then incorrect coding, of procedures that include ultrasounds and imaging. For the OIG work plan, this year, they're looking at Part B psychotherapy services payment, Part B laboratory services payment, and then, of course, your managed risk adjustment data, doing a targeted diagnosis review and whether those diagnoses are really supported in the documentation, facet joint procedures, Part B claims review for intravitreal injections of Eylea and Lucentis, and then, of course, with all the changes that occurred with the telehealth and expansions in PHE, they will be looking at that this year as well. So I have included the links to the actual sites that I retrieved my information. Again, I look at these sites every year just to kind of see what they're focusing on. I may keep a more detailed eye on those things as they come across a review that I'm doing, and then provide recommendations and feedback. That is the end of my presentation, and I will give it back to Molly.
Thanks, Vanessa. Thank you guys so much for joining us. We will again be sending out an email later this afternoon with the slides and the recording of this presentation, as well as a registration link for our next webinar, which will be in 2 weeks on Wednesday, February 24th, from 11 to 11:30 a.m. Pacific time. And that will be presented by our Executive VP of Operations, Jason Coffin, on the 6 self-pay must-dos in 2021. So we hope to see you then. Thank you so much and have a great rest of your day.